On behalf of the Chronic Liver Disease Foundation, I'd like to thank you for joining us for today's webinar entitled Epidemiology and Pathophysiology of NAFLD-NASH. This webinar is the first in a series of 4 NASH educational offerings. We encourage participants to enroll for all 4 events as the content is additive. I am your host, Jerry Mayberry of Echosens North America. Today's webinar is funded by Echosens North America, the inventors, manufacturers, and distributors of the FibroScan technology. This presentation includes information on the uses of the FibroScan technology from published literature. Echosens does not intend to make any specific claims found in this presentation. The FibroScan is FDA cleared as an aid to the diagnosis and monitoring of patients with chronic liver disease as a part of an overall assessment of the liver. It is not intended for the treatment of any specific liver disease or condition. Before I introduce today's speaker, please be aware that all participants are muted to sustain sound quality. If you have a question during the presentation, please type it into the questions pane displayed on your computer screen. When we enter the question and answer period of the event, the aggregated questions will be read to Dr. Younossi for his response. We apologize in advance if we do not have time to answer all submitted questions. Now I wish to introduce today's speaker, Dr. Zubair Younossi, Chairman and Professor of Medicine at Inova Fairfax Medical Campus. Dr. Younossi.
Well, thanks very much for that introduction. I'm Zubair Younossi. I'm Chairman of Medicine and Professor of Medicine at the Inova Fairfax Medical Campus in Falls Church, Virginia. My disclosure is listed below. Non-alcoholic fatty liver disease or non-alcoholic steatohepatitis. Let's just get some definitions straight. NAFLD is a spectrum that includes not only non-alcoholic steatohepatitis or NASH, but also NAFLD or just pure steatosis. Now, fatty liver requires at least 5% deposition of hepatic fat. On the other hand, NASH requires specific pathologic criteria that we'll talk about later on. Other causes of liver disease can also be excluded, including alcoholic fatty liver disease. The spectrum of NAFLD includes, of course, not only steatosis, NASH, but also liver cancer in different stages of fibrosis, including cirrhosis. The prevalence of NAFLD worldwide, the Pacific, has been increasing over the past decade or so. There is plenty of evidence from South Korea, Shanghai, Taiwan, and Indonesia that this prevalence rate has increased over the past decade or so. In the Middle East, as I mentioned, there is very high prevalence of NAFLD between 25 to 30%. The highest prevalence, of course, has been reported from Turkey in the recent years. In Latin America, the prevalence is also quite high, and it correlates with obesity, with some of the highest prevalence rates being reported from Mexico, as well as Brazil. The lowest prevalence is from Colombia and Peru. The prevalence of NASH in general population has not been very well studied, whether it's in Europe or North America. Or the rest of the world. In Europe and North America, the prevalence is about 1.5 to 6.5%. In Latin America, the prevalence of NASH, which requires a specific diagnostic category, is about 6 to 18%. When you look at the disease burden in the special population, especially the type 2 diabetics, this is a meta-analysis that was presented last year at the liver meeting. The prevalence of NAFLD in patients with type 2 diabetes is about 55%. And when you look at the prevalence of NASH in this group, it is about 33%, meaning that about maybe 65 to 70% of those NAFLD patients with diabetes who get biopsied will have underlying NASH. And the prevalence of advanced fibrosis meaning stage F3 or higher, is about 17%. Although we mentioned that NAFLD is associated with obesity and type 2 diabetes, there is a group of patients who have lean NAFLD. That prevalence in the United States is about 7.5%. The prevalence is higher in certain Asian countries, especially in the rural areas. Higher rates of lean NAFLD in rural areas than in the urban areas have been reported. What's behind the epidemic of NASH and NAFLD? And of course, this has to do with the prevalence or epidemic of obesity worldwide. In 2016, about 2 billion people worldwide were overweight or obese. And about 340 million children were overweight and obese worldwide, which is quite a large number. And of course, not only obesity causes a number of complications, but it's also associated with higher mortality and significant economic burden. The hepatic manifestation of obesity and type 2 diabetes and other metabolic conditions is non-alcoholic fatty liver disease. When you look at the burden of non-alcoholic fatty liver disease, of course, one is how common it is. The second piece is how progressive it is. So as you can see in this slide, there is a progressiveness of NAFLD that goes from non-NASH to NASH in different stages of fibrosis and then, of course, cirrhosis. It's important to remember that cardiovascular mortality is the most common cause of death in patients with non-alcoholic fatty liver disease. Nevertheless, NASH patients are at risk for cirrhosis, liver mortality, and liver transplantation. This is not a one-direction progressive course. There is a lot of fluctuations of both progression and regression, which makes the natural history of this disease quite complicated. Now, patients with non-alcoholic steatohepatitis can also develop liver cancer. In the cirrhotic patients with NASH or patients with advanced fibrosis, that rate is about 2.5% to 2.5% per year, which is probably about half of what you see in a patient with hepatitis C-related cirrhosis. It's also important that patients with NAFLD who do not have cirrhosis can also develop liver cancer or hepatocellular carcinoma. That rate is actually quite low at 0.5% per year. So it does not qualify for screening patients with NAFLD because that rate has to be significantly higher than that. But certainly patients with NASH and advanced fibrosis should be screened for hepatocellular carcinoma. Let's look at long-term outcome of patients with NAFLD. This is a study looking at liver-related mortality of patients with biopsy-proven NAFLD. And about 59% of these patients had biopsy-proven NASH. With about 12 years of follow-up, you can see that patients that had NASH had higher mortality or lower survival. And in fact, in a multivariate analysis, NASH was independently associated with higher liver-related mortality. On the other hand, there is other evidence that NASH may be becoming more common, and this is a study from Haynes data set looking at two sort of periods, 1999 2002 and 2009 to 2012. And as you can see, there is actually an increase in the number of patients with cirrhosis, almost doubling the rate of NAFLD-related cirrhosis in this general population that's been reported. So NASH is becoming more common as depicted by the data from Haynes. Evidence related to NASH is development of HCC. This is from the Sears database of about 5,000 HCC cases. And of course, there is also about 15,000 controls without HCC or liver disease. And as you can see, the most common etiologies of HCC was the known liver diseases of hepatitis, viral hepatitis, non-alcoholic fatty liver disease, and alcoholic fatty liver disease. But when you look at the mortality after 1 year of diagnosis, non-alcoholic fatty liver disease had the lowest mortality. And this actually was significant after controlling for confounders. Other evidence suggesting that NAFLD and NASH are becoming more common comes from liver transplant data. This is data from the Younossi the Transplant Registry in the United States. Again, as you can see in the blue line, the number of patients getting listed for liver transplantation from hepatitis C has been declining. In contrast, in gray line, you can see that the number of patients who are getting transplanted for NASH in the United States has been increasing. And although this is a few years old, about 3 years old or so, it seems that NASH is becoming rapidly the most common indication for liver transplantation. Another interesting study is this liver transplant data set for NASH-related HCCs in the United States. Again, as you know, HCC is an indication for liver transplantation. And when you look at the indication for transplantation related to etiologies of HCC, patients with NASH have the most rapid increase in HCC-related indication for being on the transplant list in the United States. Again, other evidence suggesting that NASH is becoming a common and important cause of liver disease in the United States and worldwide. So are there any predictors of long-term outcome? This is again a study of liver biopsy, almost 450 patients with biopsy-proven NASH. When you look at multivariate analysis to see what's associated with advanced fibrosis, it's having a liver enzyme and having type 2 diabetes as well as some demographic components. In fact, the more component of metabolic syndrome, diabetes, hypertension, visceral obesity you have, the higher the risk of advanced fibrosis. Another study that confirmed this is from NHANES, looking at mortality. So this is NHANES 3, NAFLD cohort of about 3,600 patients with follow-up. And as you can see, the more component of metabolic syndrome you have, the lower the survival. Finally, are there any histologic features or pathologic features that can actually predict mortality? And this is a study of biopsy proven NAFLD patients. And as you can see in this table, most of these pathologic features in univariate analysis were associated with lower survival or higher mortality. On the other hand, when you perform a multivariate analysis, only significant fibrosis stage of 2 or higher was independently associated with liver-related mortality. This was confirmed by another international study of NAFLD of 619 patients, again showing that stage 2 or higher was associated with increased mortality in multivariate analysis. And finally, in a meta-analysis of multiple different studies of almost 1,500 patients, again, stage of fibrosis of 2 or higher was independently associated with mortality. Therefore, is now a common belief that stage of fibrosis seen on liver biopsy is an important and probably the most important predictor of long-term outcome. Now, it's also important to note that having steatohepatitis on a biopsy is also important because NASH predicts advanced fibrosis. Advanced fibrosis predicts liver-related mortality. There are some other data that suggest a worrisome pattern in terms of future prediction. This is a readout that looked at the NHANES data set between 1988 to 2016 with about 59,000 adults with chronic liver disease. And as you can see in the top line, there is actually an increase in the cases of non-alcoholic fatty liver disease. In contrast, in the bottom, as you can see, chronic hepatitis C is declining. So non-alcoholic fatty liver disease not only is already the most common cause of chronic liver disease in the United States, it's actually going to become even higher in terms of its prevalence. Another set of data that came from the mortality files from the United States between 2007 and 2017 clearly shows that, again, mortality related to NAFLD is increasing, while mortality related to chronic hepatitis C is actually decreasing. Chronic hepatitis B is actually stable, maybe there is a slight increase in chronic non-alcoholic liver disease-associated mortality. Another way to actually look at future burden of non-alcoholic fatty liver disease, non-alcoholic steatohepatitis, and it says the adverse outcome is to perform modeling or Markov modeling. This is basically looking at what will happen in 2030 from the rates of diabetes and obesity in 2015. As you can see, both stage 3 and stage 4 fibrosis due to NASH is expected to double in the rates by 2030. And as you can see on the graph on the right, not only the prevalence of NAFLD, NASH, and advanced fibrosis increases, but also cases of decompensated cirrhosis, liver cancer, as well as liver-related deaths are all expected to increase. Now, it's again not unique to the United States. When you look at Europe and some of the Asian countries, again, not only the prevalence of NAFLD is expected to increase substantially, but all the outcomes that we just mentioned, whether it's actually in China, Germany, Japan, Italy, or countries in the Middle East, are expected to increase. Finally, it's important to recognize that there are a number of non-liver-related outcomes that have been associated with non-alcoholic fatty liver disease. Type 2 diabetes, cardiovascular disease are, of course, very well known. More recently, there's been a suggestion that NAFLD may also be associated with non-liver malignancy. This is actually a study in this table on the right that looks at not only liver cancer, but shows that stomach cancer and pancreatic cancer are also significantly higher in patients with non-alcoholic fatty liver disease. Another important outcome from patient perspective, it's patient-reported outcomes. These are things like quality of life. This is a study of about almost 1,700 patients from Stellar 3 and Stellar 4, patients who have biopsy-proven NASH with fibrosis. And the 3 different graphs you have are 3 different questionnaires, short form 36, which is basically a generic quality of life questionnaire, CLDQ NASH, which is a disease-specific questionnaire, and WBP-PAI, which is a questionnaire for work productivity. And as you can see, utilizing any of these questionnaires, patients with NASH have lower quality of life and their physical aspect of their PROs than both general population, and these PROs actually worsen as disease become more advanced. In fact, when you compare patients with NASH to patients with chronic hepatitis C, this is a case-controlled study of over 1,300 patients with now biopsy-proven NASH and advanced fibrosis and biopsy-proven chronic hepatitis C. You'll see that NASH patients had physical health PRO impairment, especially in physical function, bodily pain, general health, vitality. On the other hand, chronic hepatitis C had lower mental health PROs. And this is actually true even after you control for some confounders that NASH independently is associated with with lower physical PRO scores, while hepatitis C was associated with lower mental health PROs. And that, of course, is counter to the argument that NASH is an asymptomatic disease. Because as you can see that with a validated questionnaire, you can see that these patients do suffer from quite a bit of quality of life impairment. Economic burden of non-alcoholic steatohepatitis and advanced NASH is quite significant. This is a Markov model estimating the economic burden of non-alcoholic steatohepatitis. And it seems like the lifetime direct cost of all NASH is over $200 billion. When you look at lifetime cost, direct cost of advanced NASH is if 3 and higher, it's almost about $100 billion. So NASH and advanced NASH could be significant in terms of economic burden to the society. Now let me just spend a few minutes about pathophysiology of non-alcoholic fatty liver disease and NASH. It's important to remember that NASH is a multi-hit disease. It means that this means that NASH itself and NAFLD is really a phenotype that could result from multiple different pathways. And we'll just review some of these pathways. For example, there is significant evidence that visceral adiposity, either through lipolysis or through the production of inflammatory cytokines, as well as some inflammatory adipokines, can actually worsen insulin resistance and actually can damage the liver, leading into steatohepatitis. Other, of course, cause that could be playing an important role is dysbiosis through bacterial overgrowth or other mechanisms. There is a suggestion that through a number of mechanisms, bacterial translocation can lead into direct damage to the hepatocytes. And this, of course, can be direct damage to liver cells or direct damages of these bacterial byproducts, or through worsening insulin resistance and worsening inflammatory milieu that's seen in these patients. Also, of course, evidence for oxidative stress through mitochondrial stress, and there are plenty of evidence suggesting that patients or some patients with NASH may suffer from mitochondrial dysfunction, leading into lipid peroxidation of the hepatocyte membranes, and ultimately leading into damaged liver cells or evidence of liver cell damage. Finally, inflammation, of course, can also play a role through a number of inflammatory cytokines, both through not only through inflammatory cytokines, but also inflammatory cells that lead to development of scar tissue and fibrosis, as well as hepatocyte damage related to seen as hepatocyte necrosis and hepatocyte ballooning. Now let me spend the next few minutes on clinical presentation and diagnosis of non-alcoholic fatty liver disease and non-alcoholic steatohepatitis. As I just said, that most symptoms of non-alcoholic fatty liver disease are pretty non-specific. Fatigue, some right upper quadrant, sort of dull ache, could be the only presenting symptoms. But if you use a questionnaire for quality of life, you can see that there is significant impairment of patient-reported outcome. When you look at liver enzymes, they're usually mildly elevated, mostly in transaminases and rarely alkaline phosphatase. You have to make sure that there are no other causes of hepatic steatosis, that there is no significant amount of alcohol except excessive alcohol use, and other causes of liver disease have been excluded. How to diagnose NAFLD? You can look at sort of the performance of a number of different tests. In my view, looking at ultrasound or any other imaging modality, you can, of course, get a pretty good idea that the patient has non-alcoholic fatty liver disease. Of course, liver biopsy, and in my view, even MR, PDFF are very highly specific and sensitive to diagnosing fatty liver disease. On the other hand, when you're trying to diagnose NASH, there has been a lot of attempts to develop non-invasive blood tests. As you see in this table, none of them actually have been validated. So in 2019, liver biopsy remained the imperfect gold standard for diagnosing NASH. And the minimum criteria for diagnosing NASH is to have not only fat, more than 5% fat, but evidence of liver cell damage, for example, ballooning of hepatocytes, or Mallory Dink bodies. Now, if you see peripheral fibrosis, that will also strengthen the diagnosis of NASH. And of course, some pathologists would like to see some lobar inflammation when they make diagnosis of steatohepatitis. Application for liver biopsy is that you have abnormal liver enzymes. There's some indication there may be advanced liver disease in the context of metabolic syndrome. Patient have slightly low platelet count. All of these could suggest that there may be significant fibrosis and maybe steatohepatitis. But of course, there are disadvantages for biopsy, primarily related to complications, and there is always a sampling variability that can be seen with histology and liver biopsy. So there's been a good effort to develop non-invasive tests, and you can sort of divide them up into three different categories. the clinical tests or clinical laboratory tests, imaging, and then biomarkers. And I'm just I'm going to focus on the ones that are bolded over here over the next 10 minutes. So some of the commonly used fibrosis tests that just rely on the clinical and laboratory data that's available are listed here. The one that I commonly use is FIB-4 NAFLD fibrosis score. These formulas are available in the internet, and you can see that when you actually look at a FIB-4 of greater than 3.25, that suggests basically that the patient has advanced fibrosis. Or if you have an APRI of more than 1.5, that's just also significant fibrosis, or a NAFLD fibrosis score of greater than 0.676, all suggest advanced fibrosis. These tools can be used as the initial screening test to sort of find out if your patients, say with diabetes or with other component metabolic syndrome, could have significant fibrosis. Advanced fibrosis with these clinical prediction rules and their performance, their area under the curve is okay. It's about 0.8 in general, not terribly good, but at least, like I said, it'd be useful in the context of initial screening. It suggests that there are a number of other biomarkers that are serum-based, and their performance is also about 0.8. Some of them are listed over here, but probably the test that is available in Europe but currently not available in the United States is the ELF test or Enhanced Liver Fibrosis Test. And it has really these three components of fibrogenesis and fibrolysis: procollagen 3-NP, hyaluronic acid, and TEMP1. Now, when you look at these tests and your appropriate cutoff points, they're pretty good negative predictive value, and could have also pretty good positive predictive value depending on what cutoff you use for ALT score. So here is a table or a graph showing fibrosis stage and where do you see the scores correlating with different stages of fibrosis as modified Brunt criteria. There has been some recent suggestion from two phase 2b clinical trials of simtuzumab suggesting that ALT test using different thresholds obviously can actually predict the progression to cirrhosis or development of liver-related clinical events. But these studies must be replicated and validated. Imaging biomarkers, it's important to note that fibrosis has no molecular signature to detect that can be detected by imaging techniques. So there is an attempt to indirectly assess fibrosis. There are many ways to look at this biomarker. Stiffness is probably the best one, and this is based on the rationale that fibrotic collagen deposition causes parenchymal rigidity that can be assessed by liver stiffness measurement or elasticity. If there are different technologies used, vibration-controlled transient elastography, FibroScan is one of these examples. It's probably the most widely used. There's also shear wave elastography and acoustic radiation force samples, which is another way of assessing liver stiffness on just a single region of interest. MR elastography is another technology that we will review in just a minute. Look at the liver stiffness measurement for fibrosis, and you're looking at these higher stages of fibrosis, especially cirrhosis. They're very, very good in ruling out cirrhosis, and especially when you look at a at a range of about maybe around 10 or more kilopascal. So liver stiffness is measured by kilopascal. Hepatic ketosis is measured by CAP, which is another way of actually assessing hepatic steatosis with transient elastography. And again, CAP is very good to rule in presence of hepatic steatosis. Now, the grade of steatosis itself may not be that important. So once you establish presence of steatosis, that by itself would be helpful to document NAFLD, obviously. There are some specific clinical questions that can be answered through liver stiffness, and that, of course, you have to change the cutoffs based on your question. For example, in this study, when they wanted to exclude patients with significant fibrosis, for example, those who had fibrosis stage less than 2, to reassure patients, then a cutoff point of 5.6 or 5 to 6 was actually had pretty good sensitivity. On the other hand, if you're looking to see if your patient has significant fibrosis of F2 and higher, and you do this to look at patient's outcome or potential treatment recruitment, then when you're getting to about a liver stiffness measurement of about 11 or higher, then you have also very good specificity. For advanced fibrosis, again, about stage about a range of about 12 to 13 will help you, sort of look at those patients with having significant fibrosis and possibly cirrhosis. They want to study that not only elastography and liver stiffness measurement can give you an idea about stage of liver disease, but also can be helpful in terms of prognosis. This is looking at patients with different liver stiffness measurements in terms of kilopascal, and those that were close to stage 4 fibrosis, which in this case would be higher than about 12 and higher, mortality of overall survival of these patients were affected, high mortality and lower survival. I mentioned liver stiffness can also be measured by MR elastography, and a cutoff point of about 3.63 seems to be a good cutoff point for significant fibrosis. So a higher cutoff of when you get to about an MRE cutoff of or value of 6 or higher kilopascal, then you're talking about the more advanced stages of fibrosis. Another important component of assessment that would be helpful and for patients with NAFLD is hepatic steatosis. And MRI PDFF can actually do this. In this context, fat or triglyceride has a chemical signature that can be detected by MR spectroscopy. Well, of course, MR spectroscopy has a number of weaknesses, which leads to a number of confounders and confounding sort of issues that is actually removed by using MRI PDFF. So MRI PDFF have already been shown to have good correlation with morphometric fat, meaning quantifying fat by morphometry. So, of course, MRI, PDFF, and MRE can be done at the same time. Will give you both stiffness and quantification of fat. They're pretty accurate. They're probably more accurate than transient elastography. However, accessibility of MRI is not something that you could use this as a point of care. In this context, transient elastography is a much more clinically useful test that can be used as a point of care for these for patients with non-alcoholic fatty liver disease. And in this context, I think it's important to remember that a combination of non-invasive tests can actually be even more helpful. This is a study that was presented at the last liver meeting at the AASLD and used almost 3,200 liver biopsies from Stellar 3 and Stellar 4. And some of these biopsies were used for development of cutoff points and then others for validation. And when you look at these tests, NAFLD fibrosis score, FIB4, ALF, and transplant elastography by themselves, the intermediate cases, or cases that you cannot tell if the patient has a significant fibrosis or advanced fibrosis or has early fibrosis, it's quite a bit. It could be up to 40 to 50%. On the other hand, if you have a two-step sequential approach of, say, FIB4 followed by ALF, or FIB4 followed by FibroScan or transplant elastography, you can see that you actually reduce this indeterminate cases to 18 to 20%. However, if you use three sequential tests of, say, FIB4 followed by ALF followed by a FibroScan, the indeterminate cases fall to about 9 to 10%, which is quite good. However, you have to put this in the context of the fact that we don't have ALF available in the United States, but we certainly have transplant elastography available, which could be used in clinical practice. Now, let me spend 5 minutes on treatment of non-alcoholic fatty liver disease. In this context, it's important. This disease, this is related to, of course, obesity, so there has to be a public health sort of intervention that's multi-pronged to address the issue of obesity in general population. As I mentioned, patients with NASH and advanced fibrosis and NASH are those that have that are at risk for mortality. So these are the patients who actually are targets of treatment, and the therapeutic targets could be a number of different sort of mechanisms, improving hepatic metabolism, improving insulin sensitivity, improving inflammation, and improving fibrosis. Of course, issue that's always important is weight loss, to see if you can achieve weight loss. In fact, in this very important study, if you want to improve fibrosis, which is what we want to do in most of these cases, you have to lose about 7 to 10% baseline weight. But if you just want to improve steatosis, a small amount of weight loss of 3 to 5% can actually achieve that. Of course, the biggest problem with weight loss is not only that it's hard to achieve, but also hard to sustain. This is a meta-analysis of 7 clinical trials, suggests that only 15% of those who actually lost weight were successful in maintaining that weight loss. Of course, there are other modalities like bariatric surgery, bariatric endoscopy, but those are really not currently approved for treatment of NASH. So weight loss can be effective, but hard to achieve and maintain. Now, how about exercise? There have been studies showing that exercise may prevent or reduce steatosis, but its ability to improve steatohepatitis or fibrosis has not been shown. So currently there are no drugs that are approved. Now, AASLD guidance document, as well as some of the European guidelines suggest that you can use vitamin E in non-cirrhotic, non-diabetics with biopsy-proven NASH, or pioglitazone in pre-diabetics and diabetics with NASH. But of course, every time you want to use these agents, you have to have a discussion about cost, about risk and benefits with patients, and of course, cost is also going to be an important issue. GLP-1 SGL2 inhibitors are again available for management of diabetes, but these currently the evidence is not there to routinely recommend these patients for treatment of NASH. A number of other agents have been actually looked at for management of NASH, and they've not been shown to be effective. The one point I'd like to make is about statins, which are quite safe for management of lipidemia in these patients, but by themselves, they are not going to have any significant efficacy for improvement of fibrosis and NASH. Now, so there are a large number of agents that are used to treat NASH in clinical trials. This is actually not a complete list, but as you can see, the different targets with different agents, and most of these are in phase 2. A few of them have actually gone on to phase 3 clinical trials. The 4 phase 3 clinical trials that are or agents in phase 3 clinical trials are sinequirvarok, which actually was a study which an agent that showed improvement of fibrosis in a phase 2 Centaur study, and the phase 3 Aurora is ongoing. Elafibranor also showed improvement of NASH endpoint in the phase 2 Golden 505 study, and currently is being assessed in a phase 3 clinical trial called Resolve It. Selonsertib had shown some improvement in phase 2 clinical trial. A recent report suggested that they did not meet improvement of fibrosis endpoint in cirrhotic patient in the Stellar 4 clinical trial. However, ASK1 inhibitor selonsertib is now being considered in this for patients with F3 NASH, and the data for Stellar 3 has not been released as of today. Obeticholic acid, which is an FXR agonist, met its primary endpoint in Flint phase 2 study, which is carried out by the NIH. The phase 3 clinical trial, Regenerate, for obeticholic acid was recently released at the International Liver Congress in Vienna, April of 2019, suggested that 25 milligram of obeticholic acid did meet the fibrosis endpoint, and but not the steatohepatitis endpoint, according to the study definition. Of course, additional data will be published soon about obeticholic acid. Let me finally talk about, do we gain any value by treating NASH with advanced fibrosis? You know, obviously, we want to find patients that have NASH. We want to find patients that have advanced fibrosis, whether we use one of the non-invasive biomarkers or any or imaging modalities such as transient elastography. It'd be important to see if society can benefit from this. And this is a Markov model that we performed, looking at the difference in lifetime quality adjusted life years gained of treatment that ultimately reduce fibrosis stage by any mechanism or prevent progression to the adverse event as compared to not treat, meaning standard of care, which is currently not to treat. All the transition probabilities and utilities came from the literature for this model, and it was only considered to treat patients that had the significant fibrosis, meaning NASH with F3 or higher. And the value of cure for NASH was basically lifetime qualities that were gained multiplied by the monetary value per quality. So how do you actually determine the monetary value of quality? It's according to what's called willingness to pay threshold, and for the United States, it's somewhere between $50,000 per quality to $150,000 per quality. So our model was based on treatment effect, and we assumed that 30% of advanced fibrosis patients with NASH will receive treatment. And when you look at this, by treating only 30% of advanced NASH population, which is almost about 2 million people, you can actually gain about 5 million qualities over the standard of care or not treating these patients. And if you even look at willingness to pay threshold of 50,000, this will actually save the society about $250 billion over the lifetime of this NASH cohort. And of course, if you consider a higher willingness to pay, then the amounts are or the value is actually even higher. So a regimen for sustained efficacy in advanced NASH can lead to substantial clinical and economic gain, at least in the United States. So to summarize, we know that NAFLD and NASH are important cause of liver disease, and they are growing globally. NASH is the predominantly progressive type of NAFLD. Fibrosis is the most important predictor of long-term outcome. NASH patients, and especially those with fibrosis, are urgently needing treatment. Although liver biopsy is the current and perfect gold standard for NASH diagnosis, a number of non-invasive tests are being developed. Liver stiffness measurement, which measures or at least estimates fibrosis, can be very helpful in clinical practice. However, in the future, I suspect there will be a combination of the liver stiffness measurement with some fibrosis score and some serum biomarkers for fibrosis will improve the clinical utility of these tests in a cost-effective manner. Correct management, just weight reduction through weight loss and exercise and lifestyle modification. Medication of vitamin E and pioglitazone are suggested by the guidelines, but they're not FDA approved. There are a number of clinical trials that are going on. What I actually believe is that future treatment of non-alcoholic fatty liver disease requires a multidisciplinary integrated team that includes not only hepatologists, gastroenterologists, where there are tools like their biomarkers or imaging modalities for measuring liver stiffness, but also diabetes experts, exercise specialists, nutrition consults, with a number of different opportunities to provide to the patients to, of course, lifestyle modifications for those who are candidates for bariatric procedures, and of course a number of new drug regimens. And in order to actually find these patients, then it is extremely important that not only we increase the knowledge, general knowledge about non-alcoholic steatohepatitis in general population, but focus specifically on primary care physicians and other physicians like the diabetes experts who see a lot of these patients, and you can use telemedicine and other technologies. So this is an important disease, and we're going to have to deal with how to manage this disease in a multidisciplinary, sort of very integrated approach with our colleagues. Thank you very much for your attention. I'll be glad to take any questions.
Thank you, Dr. Younossi, for that informative presentation. I have been monitoring participant questions during your presentation, and I will now read them for your response. To the participants, please feel free to continue to enter new questions into the questions pane on your computer, and we will continue to monitor those as they come in. First question for Dr. Younossi. Can you speak to the genetic risk factors of NAFLD-NASH?
Yeah, right. So there are a number of different type of evidence that suggests that there is a genetic component to non-alcoholic fatty liver disease, and specifically to non-alcoholic steatohepatitis. There are twin studies that's been reported by Dr. Lumba from California, suggesting that there is high rate of coexistence of NASH in these twins. In terms of the genomic testing or any kind of a genetic marker, there are a number of them again, but the one that's probably the strongest is called PNPLA3. The allele, the G allele, is actually associated highly with hepatic fat. It's also associated in some studies from Europe with severity of liver disease or histologic severity of liver disease, such as hepatocellular ballooning, presence of NASH, and presence of high grade of inflammation. So at least we have one pretty validated genetic test, the PNPLA3, that has been associated with NAFLD and NASH.
Very good. Next question. In general, is the rate of fibrosis progression different in NASH than in viral hepatitis?
I suspect that the pattern of progression of fibrosis in NASH is different than viral hepatitis. There are two probably major differences. One, I think in NASH you have these episodes of progression followed by spontaneous regression that can be followed again by progression. So there is this up and down sort of progression rate that you can see. So it's hard to, for example, and that's probably what can explain the 10 to 20% what called the placebo rate in clinical trials that you see, is that there's a lot of spontaneous regression that you see in patients with NASH. I think if you want to look at averages, I would suspect that the progression of NASH is probably half of that you would see in hepatitis C. In fact, if you look at one type of progression, not fibrosis, but incidence of hepatocellular carcinoma, the rate in NASH patients with advanced fibrosis is about 2.5%, and when you look at hepatitis C with advanced fibrosis, it's about 5%. So it's about half of that rate. So I suspect that in general the rates are slower, but the complexity of progression of fibrosis is quite interesting and in fact much more complicated than viral hepatitis.
Next question. A significant number of the potential NASH therapies appear to focus on the metabolic side of the disease. What is your opinion of the role of metabolic syndrome versus the inflammatory component as a driver of damage?
So metabolic syndrome or a component of it such as obesity is a pro-inflammatory state. So they're all interconnected. For example, visceral obesity, which is a component of metabolic syndrome, is really the culprit there is white adipose tissue, which is an endocrine organ that actually secretes a number of adipokines and cytokines. Some of these cytokines are pro-inflammatory. However, if you are looking at targets, I think from my perspective, a single target treatment probably will not work unless you're really targeting the root of the problem, such as drugs that completely improve obesity and type 2 diabetes, which will be very hard to target, although there are some potential agents there. So in general, I would say that the most attractive option would be to have regimens that has multiple different sort of components. So a multi-drug regimen that not only focus on improvement of metabolic sort of abnormalities, but also inflammatory and even other sort of pro-fibrotic sort of pathways that can be addressed simultaneously. But at the end of the day, if you want to maintain sort of the efficacy, then the metabolic sort of abnormality that drives this disease needs to be managed.
Very good. Now we have a lean NASH question. What would you recommend for a Caucasian 30-year-old male, non-drinker, no viral hepatitis, no evidence of dyslipidemia? What would you suggest other than diet and exercise?
I think at this point, you have to make absolutely sure that there is no evidence of insulin resistance. And I use a pretty easy test, which is HOMA. Then, based on a HOMA score, so if a HOMA score is more than 3.5 or so, then that patient has insulin resistance. So that's one thing that has to be sort of considered, because most of the lean individuals still have some evidence of insulin resistance. Pure lean NAFLD without any evidence of insulin resistance or obesity are quite rare. Now, if you have a patient that has absolutely no evidence of insulin resistance or any other component of metabolic syndrome, then I think the treatment will be based on what type of pathology you're dealing with. If it's just fatty liver and you don't have a liver biopsy, obviously, then you can just exercise and lifestyle modification. If there is no diet, then it will be just lifestyle modification with exercise. That will improve insulin resistance at the muscle level. That could potentially be helpful. Now, if you have someone that has NASH on the biopsy, then the recommendation would be to use vitamin E. That's the AACD guideline that recommends vitamin E for the patients who have biopsy-proven NASH without diabetes or without cirrhosis.
Very good. Next question. We have increasing information coming in on manipulation of the gut microbiota. What is your impression does this have a promising future?
I think this is now again, coming back to the NASH phenotype, and when I was showing the pathogenic pathway, there are multiple different pathways that can get to the phenotype of NASH. And for some patients, this may be related to gut dysbiosis, and the role of gut microbiome would be important. So in that context, I think manipulation of the gut microbiota in the future may be one of the regimens that can be used. It may be that one has to be able to sort of target and find those patients that have dysbiosis as the primary or the most important pathway that's leading to NASH. Is there any evidence right now with the current regimens from what the regimens that exist currently? At the moment, the evidence does not really support the use of over-the-counter medications such as the probiotics that exist. But I'm sure there are going to be clinical trials looking at better sort of preparations and regimens in a more controlled fashion in the future.
Very good. Next question. You mentioned the tendency for spontaneous regressions of NASH. In this circumstance, would you expect to see a decrease in fibrosis as well as an improvement in liver enzymes and the other biomarkers?
Absolutely. I think you can have a spontaneous regression of fibrosis in patients with NASH. And in fact, that's what clinical trials have shown. In the placebo arm, you can have from 10% up to 20% spontaneous regression of fibrosis by one stage or sometimes even more. So, and that happens, and I think in that context, you could also see improvement of liver enzymes. In fact, if you follow patients with NASH over time, there are periods of time that their liver enzymes are normal. So one sort of could envision the situation where there is a period of time that whatever pathway that's actually promoting development of NASH or promoting progression of NASH is very active, and then spontaneously would regress. Exactly why is that going to happen? There is probably some suggestion that if you have weight loss, that you can improve things, and then if you actually have weight gain, then things can worsen. But really, we don't know. We don't know exactly what causes this spontaneous progression and spontaneous regression. What other components in the environment or in the diet or other things that we actually do can impact this. So it'd be an important question for research, but certainly spontaneous improvement of NASH can happen, and spontaneous regression of fibrosis can happen in patients with NASH.
Very good. We have approximately 2 minutes left, so I will pose the final question. You talked a good deal about the anticipated increase in liver transplant associated with the fatty liver epidemic. What do you envision will be the impact on the demand for liver transplant donors and the likelihood that those donors themselves will have a steatotic liver?
In fact, there is actually quite a bit of evidence that the prevalence of fatty liver disease in the donors is quite high. In fact, some of the data in terms of prevalence of NAFLD came from the donor population. Now, historically, fatty livers were not very were not very enthusiastically used for liver transplantation. But that data is that approach is changing, and most patients with some degree of fatty liver, most donors or liver donors can be utilized. So I think the number of patients with fatty liver on the transplant list will continue to increase. And what we have to do is to sort of manage their metabolic abnormalities that can occur post liver transplantation, as well as on the transplant list. And the use of fatty livers is for transplant is something that needs to be better studied, and some of these patients could be good donors, but we just have to have better data.
So thank you, Dr. Younossi. That was a tremendous amount of highly useful information. I wish to inform the participants that they will receive a follow-up email message with a link to the recording of this event. Please feel free to share that link with your colleagues who weren't able to make it to today's webinar or to listen to it yet again to capture more details. I urge all participants to complete the registration and to attend the second webinar in this four-part series, which will be given on May 8th by Mazen Nuruddin, and he will be speaking to the topic of diagnostic tools in NAFLD-NASH. Thank you to everyone for participating. Good day.
Thank you.